I would like to welcome you to this presentation. My name is Adrian Neal. I'm a consultant clinical psychologist and head of employee wellbeing for Inreach Health Board. And together with my colleague Sophie Jones and Dr. Naomi Swift, we would like to share with you some of our experiences and innovations from working within a employee wellbeing framework during the pandemic. Some context, I guess, just to take you back to late March, early April this year. I'm sure all of us were suddenly waking up to the reality of the scale of the pandemic. From my perspective, I like to try and be as evidence-based as possible, and my challenge was to try to look for evidence to create a model which might support employee wellbeing within an ABUHB University Health Board. And the immediate issue was there wasn't a lot. So scouring the literature, speaking to colleagues, trying to gather as much evidence as possible, we realized there were some threads of evidence from around the world relating to various pandemics. But given this was an entirely new scenario, we really had to be creative and learn and invent as we go. We also had to consider reorganizing our wellbeing service, which was predominantly focused on supporting individuals. We now had to think of how could we support whole teams of people on the ground with very limited time and very limited resources. So the plan that was devised, we called that the hub and spoke strategy. The idea was to use an army of volunteer redeployed staff and natural allies working across our health board, of which there are about 15,000 people, to create local wellbeing hubs or spokes that would be coordinated but not micromanaged by the hub. And to do that, we needed some really experienced, autonomous and capable colleagues. And I was lucky enough to have have access to a number of senior and experienced psychology colleagues who were redeployed from across the health board. So the advantages of doing this and creating these local teams were people get access to help quickly. They were visible, they could be really flexible. Because they were trained, highly skilled, senior, they were able to connect into these systems and respond very, very quickly and not need management from myself, which at that point was impossible to do. So we had to really rely on people's ability to function independently. It was incredibly complicated to pull together. We couldn't really standardize, and we really never understood how the emerging need relating to face-to-face work and remote work and what people's needs would be as we evolved and worked through the pandemic. So it was very much learn as you go. But the model itself proved to be quite robust and a very useful resource. So this slide really identifies the 14 different employee wellbeing spokes, and if you look at the illustration, so we've got the hub in the middle, which is my core service, acting as coordinating, resourcing and supporting the various hubs as the various spokes as they developed. Now if you look quickly, you can see that they're covering everything: primary care, physical health wards, whole hospitals, divisions, specialisms. We could have had far more, but we ended up with 14 core spokes. And to give you some more information and to explain how these spokes, all of which were very different, functioned, we have Sophie Jones, who is the assistant from the Wellbeing Service, who took a lead in the facilities and estate spoke, and Dr. Naomi Swift, clinical psychologist, who led the therapy spoke. So we'll now move on to hearing from them to see how their specific approach to supporting staff during the pandemic, how it panned out. Thank you.
Our initial objective was to engage with the states and facilities, develop a broad understanding of their current wellbeing related needs, and then draw up a plan that will help us to meet and support those needs. During the first wave of COVID-19, we developed an Inreach initiative to provide on-site wellbeing support to the Estates and Facilities Division. This initiative was developed based on several divisional challenges that were identified in earlier one-to-one conversations that were held with management. These one-to-one consultations highlighted that this division has increased challenges due to the structure and roles fulfilled. The structural differences in comparison to other divisions mean that staff tend to fulfill roles that are more practical and less technological, therefore do not require frequent, if any, computer or internet access. This disrupts communication and makes access to wellbeing resources shared via online organisational platforms, such as the Health Board's intranet page, difficult to access. Online data also indicated that this division typically demonstrates a lack of help-seeking behaviour and are therefore less likely to reach out for support. We identified several confounding variables that may have also influenced this, such as age, gender and socioeconomic status. A combination of all of these factors meant the traditional outreach wellbeing support models that are often adopted in organisational settings that encourage responsibility and ownership of personal and professional wellbeing are not often successful within this division. For the reasons highlighted, it was decided that a more proactive Inreach model of support was needed to ensure that everybody had the opportunity to access support throughout the entirety of the pandemic. This approach involved us reaching out to staff and dropping into them and their working environments. This level of wellbeing support is considered innovative, as such an intimate and unique offering had never been available before to this workforce. During these sessions, we had meaningful conversations with over 450 members of staff, which is a quarter of this workforce. We were able to utilise our sessions to provide immediate emotional and psychological support to NHS essential key workers throughout potentially one of the most difficult and significant milestones in medical history. These sessions also enabled us to signpost them to different wellbeing support offerings across the Health Board and within their local area. And most importantly, we were able to signify their value and contribution to providing high quality healthcare to our patients, helping them to feel valued and cared for. Our Inreach drop-in sessions also allowed us to identify this division's specific wellbeing related needs and look at ways that we can formulate a plan going forward. Some of the needs that we identified included factors such as improved leadership visibility. We have already consulted with the divisional director, who has now incorporated leadership visibility into staff PADRs. We also recognise the need for regular on-site wellbeing support and the continuity of wellbeing check-ins. Since our wellbeing drop-ins have continued on a weekly basis across sites with critical care units. Lastly, we identified the need for improved access to support and wellbeing resources for this division. Employee Wellbeing are currently in the process of developing our own website to improve accessibility to essential wellbeing resources across the Health Board, but especially for those with limited organisational access, such as the estates and facilities.
Hi, so my pre-COVID role was as part of the weight management service within the therapies division, and along with my team, I was redeployed in March and asked to support employee wellbeing. So due to this mass redeployment in our division, we quickly recognised the importance of having a therapy spoke as part of the hub and spoke model, so I took the lead for this. So our initial approach was to consult with the clinical director and heads of profession with the objective to embed wellbeing from the top down and make a collaborative plan. Senior staff were really enthusiastic, with different heads of profession highlighting the needs of their staff groups. During the first wave of COVID, along with psychology colleagues, I ran ICU drop-in sessions, and these were easily accessible to the many therapy staff also working in these areas. People were keen that we were present during their shifts rather than them having to reach out to us, as they were so tired after work in the setting that they felt unable to seek support later on. We had posters with wellbeing tips, and a phone line was shared across the department and displayed in accessible areas. Calls to the line from therapy staff were directed to me to arrange one-to-one callback and support. And as people began to return to their usual areas of work in June and their pandemic experiences hit home, I got much busier. So team leads began to request group sessions to support staff reconnecting, and I ensured that I spoke to the leads first to understand their concerns and support their own wellbeing as well. The team sessions were based on the Health Board's Taking Care, Giving Care rounds, fostering the idea that compassion for ourselves and each other is essential for us to work effectively within the NHS. I've done 14 of these so far, reaching 130 staff, with another 6 planned. Feedback has been good and word has spread, so requests are continuing. And we've also used the format to feedback concerns and ideas to senior managers, and sustainable changes to wellbeing approaches have been made following the session, which is really positive. And whilst the group sessions were mostly face-to-face in large rooms such as physio gyms, the OT department were keen to engage with Schwartz rounds, which we tried to deliver virtually for the first time to almost 50 staff using Microsoft Teams. And despite some tech issues, the online format was deemed acceptable and a way to connect large groups of people in a supportive way as COVID continues. So overall, the impact of the spoke work has been positive, I think, and wellbeing is becoming a priority across the division, with the senior leadership team encouraging regular updates and ideas. So what next? Over the last 8 months, many AHPs have faced completely new ways of working and had to adapt and develop new skills really quickly. They've bravely embraced the challenges of COVID and have made a real difference to the response across the health board. They haven't had a specific wellbeing lead before for therapies, and I've been able to continue with this role just 1 day a week until June 2021. But given the ongoing impact of the pandemic, does the wellbeing support need to be greater and longer term?
Okay, I'd like to thank Sophie and Naomi for sharing their really important and innovative work. I'd like to conclude this presentation just by pulling together some core learning for us. Obviously, looking to the future, we really need to think about how well-being, what the challenges will be over the next year, I suspect. So what the second, third, and perhaps fourth waves of COVID bring, and how our model can potentially flex. But we're already noticing actually we don't have the same level of resources, and the systems are in a very different position, and therefore the wellbeing needs will be different this time round. So we need to continually keep our eye on that. We also need to really have a significant conversation with our colleagues in leadership positions to really work out how we support this work. It's all well and good doing this work with volunteers and sustainable or redeployed colleagues, but actually when they are not available, what do? We do need investment. We need a much more strategic approach to keeping this incredibly important work going. And lastly, what the last 6 months has certainly taught me is that we do need to think about how we respond to the wellbeing need, and how we really do need to move away from pathology and individuals, and we really need towards getting much more integrated support in teams on the ground, and really need to not just look at people's health. We need to help and understand what will help them thrive, not just survive. Not just the pandemic, but beyond. My fear is that the last 6 months has really taken its toll on people. People are tired, people are drained. This will now become the biggest challenge we have, and health models of wellbeing are really not up to meeting this challenge. I'd like to thank you for watching, and like to thank my colleagues Sophie and Naomi for contributing. I'd like to say I'm really proud of what they've done. If anyone has any thoughts, very happy for you to contact me directly. I'm sure you can find me on the global email book. Okay, many thanks. Bye-bye.